Hello everyone, and welcome to this audio podcast. It's the final audio podcast in this series, the Rogue Storm episode. And today's audio podcast is about thrombophilia. This is the Shientist, and it's another Storm Robotics production. So, a little bit of an introduction to clinical thrombophilia before getting into the sort of details around this. The term thrombophilia can be applied to can be applied more accurate to individuals or patients who have been diagnosed with a sort of suspect or develops venous thrombosis or VT spontaneously or of severity out of proportion with a particular stimulus, and also have a recurrent venous thrombotic events, and also develop VT at an early age. There's also, of course, there's also hereditary or heritable thrombophilias as well. So prothrombic states may be hereditary or heritable, acquired or mixed. So environmental factors can cause thrombophilia is from a sort of a hereditary stance, and interacting with genetic predispositions as well. There's also genetic variants independent risk factors as well. So natural anticoagulants such as protein C and S, and antithrombin or AT, and fibrinogen, prothrombin, and factor V can also be problematic in this regard. A little bit about AT or antithrombin deficiency. So generally, AT or antithrombin is synthesized in the liver and has an inhibitory effect on thrombin, and also in factor 9A, factor 10A, factor 11A, and a factor 12A in relating to clotting factors, and also heparin accelerates the rate of complex formation between antithrombin and serine proteases. Type 1 deficiency as a quantitative reduction in qualitatively normal antithrombin. And type 2 deficiency, generally from a laboratory perspective, has qualitatively has been identified as or reported as qualitatively abnormal. In addition, type 2 deficiency is subdivided according to site of molecular defect as well. So there can be reactive sites or reactive thrombin, reactive site or reactive site thrombin binding site. There can be heparin binding sites as well. There can be both, where basically where antithrombin or type 2 deficiency excuse me, has an interactive link between a thrombin binding site and heparin binding site, and so therefore can also be identified as pleiotropic. And also subtype is can be and generally are clinically important. Thrombosis is higher in association with type 1 and type 2. So a little bit around the sort of definitions around the normal range for antithrombin. So generally, in relating to the normal laboratory reference range, there's age and gender related variations, and variation minor, and there's standard international sort of units that are applicable. So it's lower in premenopausal women or females than in men of the same age, and also there's a decrease in antithrombin activity with heparin, and there's a profound decrease in disseminated intravascular coagulation, liver disease, and also in nephrotic syndrome, where there is evidence of protein leaking via and through the kidneys. So generally, in relating to the risk of thrombosis, in this particular condition, there's AT deficiency is more severe than protein C or protein S, and patients can suffer from thrombosis in those who are aged less than 25 years of age as well. Type 1 AT antithrombin gene mutations occur and have been identified in the general population, but however, the percentage around this is generally quite low, around 0.02%. Unselected patients with thrombosis antithrombin, there is a sort of a definition of around about 1%. There's a relative risk of type VTE which is around 25 to 50-fold in type 1. In relating to protein C deficiency, protein C is a vitamin K dependent glycoprotein, generally synthesized in the liver, activated by thrombin and thrombomodulin complex on endothelial cell surfaces. APC plus cofactor protein S degrade activated clotting factors of factor 5A and factor 8A. Protein C sort of deficiency. There is type 1. Type 1 it has more. There's more sort of literature and context surrounding type 1 versus type 2. However, generally both are important from a physiological standpoint. Phenotypic classification is not clinically relevant, although from a molecular basis can be important where further investigations might be required. Functional assays, specific actor protac derived protac is derived from snake venom, and APC is quantified by clotting or sort of chromogenic methods as well. PC antigen assays or molecular methods can distinguish types. However, from a laboratory practice, in some laboratories, there can be no point in conducting some of the sort of molecular methods and sort of antigen assays, since most of the most of the investigations based on particular laboratory requests are done from a sort of in line with basic sort of clotting investigations, along with some additional investigations that are done that are conducted in a hematology laboratory specifically. And also again, there's chromogenic assays that can be conducted, and chromogenic assays are used to detect pretty much all type 1 and most of type 2 protein C. And the clotting methods involve sort of factor V Leiden, but on its own, factor V Leiden is misleading and is not reliable. Factor V Leiden is not reliable on its own, and generally factor where protein C is evident, it can be low if factor 8, the clotting factor 8 is raised. And there's also where protein C is evident, there can be evidence of hyperlipidemia, but however it can be potentially low. And then there's also unreliable protein C assays are pretty much unreliable in the presence of lupus anticoagulant as well. Protein C sort of reference ranges sort of differ from antithrombin somewhat. However, PC activity levels are related to age and gender as well, and there's reduced PC activity observed in disseminated intravascular coagulation, liver disease, coumarin therapy, and in the general population is within the general population, the percentage around this is 0.2% to 0.3%, and unselected in VTE patients, which is about 3%, as a relative risk of 10 to 15-fold. And where protein S is concerned, in protein S deficiency, it's a vitamin K dependent cofactor for activated protein C, or APC, 65% complex to particular markers C4b BBP, and 35% free protein S, and bioavailability linked to concentration. C4BBP acts as an important regulator, and type 2 total and free is reduced, and type 2 functional can have a defect, and type 3N total protein S is can act as an antigen, and is generally low and free in context of physiology. In related to protein S assays, there's total immunoreactive protein S. So one of the assays, or sort of historically have been used, is something known as the Laurel assays, and then there's the enzyme linked immunoassays, and the radioimmunoassays that have also been used. Functional protein S on cofactor activity defects all types of deficiency, and should reflect any investigation should reflect only protein S, and is not always the case, and there can be interference of other protein conditions, protein link conditions as well, due to for example lupus anticoagulant. So one of the main markers that in order to establish sort of abnormalities in either protein S or protein C can be lupus anticoagulant, and in coagulation laboratories linked to hematology, generally speaking, there can be a baseline investigations to look at lupus anticoagulant to kind of ensure that if there is definitely going to if there is a suspect if there's a patient or suspect risk of protein S or protein C, then to rule out lupus anticoagulant for initially is one of the steps that laboratory scientists and professionals sort of initiate first off. Then it is recommended that if low functional protein S is detected, follow up with immunoreactive assays as well. There's reference ranges around this as well. So protein S levels are slightly questionable in men in males versus females. There can be lower levels and progressively lower levels progressively in females who are pregnant or in pregnancy, and also potentially where there's women or females on hormone or on for example hormone replacement therapy, and there can be acquired protein S deficiency, and this tends to happen or has been evidenced in cases where there's a disseminated intravascular coagulation, and again where there's coumarin therapy, and in liver disease, and also where there's particular antibodies as well. There's also some prevalences surrounding this in context of in and around thrombosis. So the prevalence in the general population is somewhat unknown, owing to the fact that thrombosis it can be, and also at the same time not completely definitive, where in most conditions, most health conditions, and most issues, there can be sort of thrombosis that is undetected, and so in something that in an investigation known as the Leiden Thrombophilia study, the Leiden Thrombophilia study, low protein S was found in 3% of patients with VTE, in 2.1% in the control group in this particular investigation, and in another study 1.3% controls, and then thus only twofold increase in risk. However, the incidence in population may be sort of much lower. So the risk in some contexts could be higher. Activated protein C resistance, or APCR, and in context with factor V Leiden, activated PC resistance is impaired where there's impaired plasma anticoagulant response to APC in vitro, point mutation in the 5 gene of V gene 1691Ga, and this had been identified in context of factor V Leiden in the 90s, and alongside this, there's other sort of factors that there's other factors that are linked with activated protein C resistance and in line with factor V Leiden as well. So the lab tests surrounding this, or APCR and factor V Leiden. So APCR can be detected with activated prothrombin time with and without APC reported as a ratio. There's screening test investigations that can be conducted, and they tend to detect APCR, and it's no good if, for example, conducting sort of some of the more intricate investigations are no good if baseline activated prothrombin time is extensive. Factor V Leiden can be detected by amplification of DNA by PCR, a polymerase chain reaction and mutation detection step. And in relating to factor V Leiden prevalence and thrombosis risk, the Caucasian population, at least in literature, has highlighted that most are common hereditable and where Thrombophilia is concerned, and the percentage around this is around anything from around 2% to 15%, and more prevalent in northern Europe, according to a particular literature. 20 to 50% patients present with first episode of VTE, and heterozygotes 3 to 8-fold increased risk of VTE, and homozygotes are 80-fold at risk. A little bit about dysfibrinogenemia. Most cases are asymptomatic, but in 20% cases there's an increased risk of arteriovenous thrombosis. There's 25% bleeding tendency, and there's prevalence of fibrinogen abnormalities in venous thrombosis patients in and around 0.8%, and in thrombophilic fibrogen variants, there is a higher incidence postpartum thrombosis and pregnancy loss as well. Mechanism of thrombotic tendency: there can be a defective lysis of ABN fibrin, and there can be raised thrombin due to defective binding to ABN fibrin. A little bit around sort of the mixed etiology defects. So there can be elevated factor VIII and factor VIII and genetic and environmental factors. There's 6-fold increase in VTE. There can be hyperhomocystinemia, a 2.5-fold increase in VTE if homocysteine is more than 18.5 micromoles per liter, and generally homocysteine is a biomarker that can be used to detect other particular underlying causes from a laboratory standpoint. And then there is a molecular investigation that looks to that can be used to identify associations with VTE, and the molecular technique can help to can help to investigate sort of the variants of VTE. So from a thrombophilia testing standpoint, one of the questions is who should be investigated for thrombophilia. There's anyone with a sort of the clinical picture or history in following a history and examination can be prompted for particular investigations. Anyone where there's a personal or family history that prompts suspect for a suspect or high risk for thrombophilia, and anyone who has wherein there is in context with the evidence based in the literature, there's age, immobility, trauma and surgery, potential hormone use, and where there's females who may be pregnant as well. So in relating to the laboratory investigations or laboratory testing, one of the main sort of overarching investigations is the clotting investigations. So there's the international normalized ratio, the INR, the activated prothrombin time ratio or APTR. There's a thrombin clotting time or TCT. There's the fibrinogen or FIB. There's the factor 8 and factor 12 and factor 5 Leiden and lupus anticoagulant, protein C and S if and where after lupus anticoagulant has been investigated. Then there's also antithrombin investigation, and there is a molecular investigation that can be implemented, and that is methyl tetrahydrofolate reductase, and it's a molecular technique that most laboratories can conduct this. It's abbreviated as MTHFR. So in line with the laboratory investigations around thrombophilia or thrombophilia testing, the idea is to gain diagnostic accuracy, gain understanding of the clinical usefulness, usefulness or the appropriateness, but also the interpretation of results, the management of VTE, and to highlight how it can be prevented or prevention, and where applicable, for females, there's a context where health professionals would also provide, for example, a contraceptive advice or hormone replacement therapy advice where applicable, and also aspects around pregnancy. I want to finish there on this particular audio podcast. Here is a list of acknowledgements and one main reference. In this audio podcast, related to this audio podcast, I want to acknowledge acknowledgement to someone called Sarah Bruti, who is a hemostasis and training lead in the UK for context surrounding thrombophilia. And again, most of the context around this work can be cross-referenced through the International Society of Blood Transfusion ISBT Science Series 2020 and it's a special issue, Introduction to Blood Transfusion from Donor to Recipient, and again the publication is available to download. Again, acknowledgement to Malcolm Needs, for transfusion scientist and practitioner in the UK, for approach to hematology, and acknowledgement to Professor Ken Jones, Emeritus Professor in Immunology in the UK, for the immunology perspective. We've now come to the end of this particular audio podcast and the series in the audio podcast series in this series. So we've covered pathology automation, massive transfusion regimes, pediatric transfusion, pre-transfusion testing, the provision of blood for bone marrow transplant patients, the use of plasma products, and today we covered thrombophilia. I want to say thank you for taking the time to tune in. This is the Shientist in this audio podcast series around the Rogue Storm episode. This has been another Storm Robotics production, and thanks for checking this out.